The 13th of November, and my name is Kay Wakelin, and I'm coming to you live for Facebook Friday once again with Endocrine Cancer Australia. So welcome to everybody who's joining me today. Just before I begin, or before I go any further, I want to acknowledge the traditional owners of the land that I am broadcasting to you from today, which is the land of the Wurundjeri people, and I would like to pay my respects to elders past, present and emerging. Some of you may be aware that this week is Naidoc week. Naidoc, I had to look this up because I hear about it every year and I hadn't ever looked up what it meant. So I thought that you might be interested to know that it stands for the National Aboriginal and Islanders Day Observance Committee. And I guess it's a real chance to celebrate the history and the culture and the achievements of Aboriginal and Torres Strait Islander people. I know we've got Aboriginal and Torres Strait Islander people within our community, both as patients but also as some very trusted health professionals, and so I just really wanted to emphasise that today and pay my special respects. I say this every week, but I want to always remember it, that one of the things I'm deeply grateful about where I live is the Yarra River, which in the Woiwurrung language is called the Birrarung. And I love to go running along the Yarra River. Some of you know that I'm actually in training for a virtual Melbourne Marathon event, and there's been a few whispers about people who might like to join me, not necessarily in running. I'm going to run a half marathon because I must have rocks in my head, but there might be other people who would like to join me. So that weekend is the 5th of December, and I'll be running a virtual half marathon, but you might actually like to join me in running or walking, or doing something that weekend that is suitably pitched to your level of capacity. So maybe I'll put a link to that event on in the notes, so that if you're interested in joining me on that weekend, I would love some virtual company and some solidarity as I slog it out. But I will be doing that along the Birrarung and enjoying being out in nature that weekend. So yes, I'm gonna talk. So okay. I'm used to having, the last few weeks we've had guest experts, and so it's just me today, and so I think I was waiting to introduce someone else and my brain just escaped me. We've got a 2-week series this week and next week, and we're looking at the perhaps quite tricky subject of sexuality. I just wanted to give you some information about what to expect today and also what's coming up next week. And so, you can make some decisions about whether you watch it now or whether you watch it later or whether you just don't. And that's okay too. So this week, me being the nurse, I'm going to talk about some of the more nursey aspects to this area. And then next week we've got a guest expert, Dr Amanda Hordern, who has her PhD was entirely in the area of sexuality and cancer. Amanda Hordern is a cancer nurse, and I have worked with her for over 20 years now, which is very exciting, but to have her along to talk with you next week. So I just wanted to start by saying up front that this is a really complex area. It's not just something that kind of magically emerges when cancer's in the picture, but actually this is complex for us quite outside cancer and health issues that emerge as we get older. There's lots of cultural variations for us. There's lots of age variations in terms of how comfortable we feel talking about this. Sometimes there's painful stuff in our lives that is very much to do with this area of our lives, and so I don't want to push you out of your comfort zone. I'm not going to be talking about anything, really, I hope, not really confronting today. But if it's just not for you, that is absolutely fine not to tune in. Or you may want to come back later. The video will be up on our Facebook private discussion group where I'm broadcasting in live, but we'll also have it on YouTube. So if it just suits you to come back to it at on another day or another time, or when there's less people listening, or potentially looking over your shoulder, that's okay too. And the other thing I would just say up front is that because we're getting into some sort of medical stuff, I'm not giving you individual medical advice, and it's really important to talk with your doctor or another health professional, another trusted health professional about this. And that really leads me to the first point I want to make, and that is around dispelling some of the myths we have about sexuality and cancer. And that the first one is, if it was important, surely my doctor would raise it with me. And that was one of the key things that came out of Dr. Amanda Hordern's research, which was that doctors and nurses and health professionals had the opinion that, gosh, if this was important for patients, surely they would raise it with me. They would ask me if it was, you know, if maybe they're not even thinking about sex, you know, they're too sick to think about sex. And if they wanted to know about it, you know, if it was important, they would ask me. And then when Amanda actually, and I'm going to ask her about this research next week, so I don't want to give you too much of a spoiler, but when she went and did interviews with patients, they all said, well, if it was important, surely my doctor or my nurse or my, you know, social worker would have talked to me about it. They would have raised it. And I think actually what that reflects is that as a community we can sometimes be a bit awkward about sex, and it's a kind of a sticky thing to raise for all of us, sometimes myself included. So I just wanted to say that maybe if you've been thinking about there's been an issue for you, and you've been wondering about whether to talk to the health professionals about it, or whether there's anything that can be done to help this particular issue, maybe your health professional's been too awkward to raise it with them. And so I would just encourage you to be bold and raise it with your doctor. And you can say, look, Kate from Endocrine Cancer told me to ask you this, and blame it on me. I don't mind. They'll blame me later, and you know, but that's okay. And it's a very important part of life, that it's important to get good information from your health care professionals about. There's a few other myths that I want to just sort of dispel before we go too far further. Old people. I hear so many people say, well, old people, they shouldn't be worried about this. And actually, I think that's a complete lie. I think sometimes we get quite sort of hyper-focused on sexuality being just about sexual, like the traditional sexual intercourse, and certainly for a lot of older people that particular physical act gets a little bit more challenging with time, or happens a little bit less. But sexuality as a expression of being human, it doesn't die by the, you know, as soon as you turn 40. It continues, it evolves, it grows, it changes, but it is important for people of all ages. I think another myth is that, well, but I'm single. So, or this person's single. And we know that actually, you know, everybody has human needs for intimacy, for comfort, for connection with each other. And so I think actually there's more challenges when you're single. And, well, look, there's challenges either way, if you're in a partnership or if you're single or if you're dating. But I don't want people to think that I'm just talking to those who are in stable heterosexual relationships. And that's the next thing, is that sometimes we make assumptions about, when we're talking about sexuality, that we're just talking about heterosexual couples. And I think that's just way too narrow a definition. So I just want to, again, broaden this right out to say, I'm talking to people of all ages. I'm talking to people of all sexual orientations, all genders, and you know, whether you're single or in a relationship, hopefully this will be relevant for you. I think the other assumption that sometimes we make is, and maybe this is something that we make of the person with the cancer, and I know that we've got carers who'll be watching us today as well. My partner is too sick to worry about this, and so sometimes there can be this assumption, or sometimes it's about a fear of hurting that person or putting pressure on that person. So sometimes that can make us kind of hold back a little bit too. So before I go any further with it, this is my huge plug, and you know that I plug the Cancer Council resources a lot, but this is a beauty. So this is Sexuality, Intimacy and Cancer, and actually Dr Amanda Hordern was involved in writing the first edition of this booklet. It's gone through lots of iterations since then. But it actually gives a really good definition of sexuality that I wanted to read out. I was looking for a good way of saying, well, if it's not just around the traditional, you know, stereotype, then what is it? And so I just wanted to read this paragraph out before I then get into some specific information. So sexuality involves much more than just the act of sexual intercourse. It's about who you are, how you see yourself, how you express yourself sexually, and your sexual feelings for others. it can be expressed in many ways, such as the clothes you wear, how you groom yourself, the way you move, the way you have sex, and who you have sex with. And I just thought that was, and it goes on. Obviously, it's a really it's a very detailed booklet, but you know, I liked that paragraph because it really gave a much more broad definition for us. So I will put a link to this booklet in the notes. There's heaps and heaps and heaps of strategies, and one of the things I was worried about today as I was preparing for this talk was, oh gosh, I want to get it all in. Like I want to make sure I say everything, and I know that I just won't, because A, I'm very human, and B, there's actually a lot. There's books written on this, and this is a really good one. It's a good place to start. So there's heaps of very practical strategies for both people with cancer, but also for carers. So yes, and the other thing I would just say is that the Cancer Council do health professional training on sexuality, on communicating about sexuality for health professionals. So if you've got an awkward doctor, maybe you should suggest they do the training. Maybe that's going to be confronting, but like, I think it's good to acknowledge that this is an area that a lot of health professionals kind of struggle with, and it's okay to break the ice with them. So I've done some definitions, I've dispelled some myths. I can see a few people are looking at the feed, which is good. So did I say sticky thing? Oh gosh, okay. Maybe I'll ignore the notes coming at the side, the chat at the side. That might make me blush. So I wanted to talk firstly about sexuality as we get older, because as we said, you know, one of the assumptions we make sometimes in the community more broadly is that older people aren't really interested in sex. So I wanted to talk a bit about sexuality and older people, and some of the things that happen to us that as we get older that make it a little bit more complex or make it different, and that we've got to adjust to. So for both males and females, there are changes. Well, you know, I'm telling you this, I'm telling me this, you know, regardless of whether it's our hair, the skin on our face, the way our feet work, everything changes as we get older, and the parts of us that are, you know, more sexual, there's no difference there. So both males and females have changes to the genitals. So for the guys, that often means that the penis will get smaller and often shorter, and sometimes it can actually retract up into the body a little bit. The testicles tend to hang a little bit more lower and a little bit more free. Erections, so function also changes. So I'm going to stick with the men for a minute. Erections tend to be slower to achieve. They tend to be a bit softer. They tend not to last as long, and the period in between being able to have an erection and then the next one gets longer, and we call that the refractory period. You can also get things happening like retrograde ejaculation, where the ejaculation actually goes up into the bladder rather than out the traditional end. So that happens a bit more as we get older too. For females, we get changes in the actual tissue. So for women, the length and the flexibility of the vagina can get smaller. Having children actually really changes the female genitals, and a lot of women find that things are also a little bit lower down there, and so they can have a shortened vagina because the cervix is hanging lower. But with the hormonal changes that happen with menopause, that tissue becomes a lot less flexible, and dryness can be a real issue too. And that can actually lead to, I mean, a lot of people find that sex becomes really uncomfortable for women as they get older, but actually sometimes it's just dryness that affects walking around. So maybe I'll talk a bit about, I mean, I'll probably talk about strategies all the way through, but one of the tips that we tell women, anyone who's going through a menopause, is actually cut the soap out of that area, which can feel a little bit odd because we're used to being, you know, trying to be very clean down there, but actually using something like sorbeline can be a far more gentle alternative to soap and help moisturize that area. The other thing that you can do is, if you're just dry down there, just because you know, of that age, or that your hormones have dried up, using a water-based lubricant after the shower, like, you know, you moisturize your face, you might want to moisturize down there too. Might make it more comfortable just in the everyday, you know, walking, running, exercising, and maybe having sex, but you know, as a more of a day-to-day comfort level. A lot of people find also their pubic hair thin, so you can go thin on the top, but you can also go thin down the bottom, which is a bit of a surprise for people. And actually, you do go grey often there too, which we don't talk about this in normal dinner table conversation. But I guess if you've signed into this talk, then you're up for it. So let's go there. So the other things that happen for both guys and women and men are that we have other things that crop up, and cancer is certainly one of them. But you know, most people who are older will have some creaky joints and some, you know, arthritis or some joint pain or some, you know, it's not as easy to get around. So physical mobility is a little bit more challenging, and that can affect us in the bedroom and the way that we can interact with our partner or the people that we love as well. There are other health medications that can really impact on our ability to sexually relate to each other. So things like blood pressure medication or hormone therapy, and I'll talk a bit more specifically about hormone therapy in NETs. But you know, blood pressure medication can reduce the ability to have an erection. You know, and there's other medications that can make you feel tired or you know, have other side effects that can be impactful in the area that we're talking about today. So I wanted to then go into cancer and talk a bit more about cancer and what we know about the impact of cancer treatments and cancer itself on sexuality. So I'm going to go through some of the main treatments first. So just starting with surgery, because that's often where we start. We often get sent to a surgeon, so that's often the first thing that happens to people with cancer. Surgery obviously leads to a change in body parts, and depending on the area that's being operated on, that will obviously change. But we can have scars. We can also have stomas. So you know, people with NETs can need to have a stoma because they've had a section of bowel removed, and that's often the traditional way of thinking about a stoma, is that you're wearing a bag to collect poo. But people can also have urinary stomas. So if the cancer has invaded the part of your urinary system, so the, you know, the your waterworks, then sometimes you can need to pass urine into a bag as well. Also a tracheostomy, so that's something that we don't think about very much, but one of our more rare forms of neuroendocrine cancers are paragangliomas, and they often occur in the neck. So a lot of people with paragangliomas have a lot of difficulty with swallowing, with it can affect their speech, but it can affect their breathing, their ability to take a deep breath in, and sometimes people with a paraganglioma will have a tracheostomy, and obviously that's going to really change not only just the physical act of having sex, but also your self-esteem, and a scar or any change in your body. It's got its physical impact, but then it's got its whole emotional impact as well, and just being able to adjust to that is a real challenge for people. A lot of people just don't feel attractive anymore after these things have changed. The other thing that can happen with surgery, often, well, it does happen with surgery almost universally, but usually we hope it gets better, but sometimes people can have pain ongoing after an operation and changes in sensation. So a lot of people will know I've had a lot of abdominal surgery, not because I've had cancer, but because of some other mischief in my body. I've had a lot of surgeries to my tummy. I can't really feel anything from my belly button right down to the top of my legs on my tummy skin. And so that's weird, you know, not having sensation. And if someone is caressing you, or, you know, you just want to feel comfortable in yourself and you're not feeling that sensation, that can take a lot of getting used to. It's a really strange kind of thing to not be able to feel a part of your body. Moving on, a lot of people with cancer will have a form of chemotherapy, and certainly NETs we see capecitabine and temozolomide used frequently as an oral form of chemotherapy, but a lot of people with NETs will also have IV therapy, so it might be carboplatin and etoposide for a higher grade neuroendocrine tumour, or sometimes a 5-FU infusion for like the lower and middle grade tumours. Sometimes oxaliplatin and other chemotherapies can be used. So the first thing to say with chemotherapy is that the fluid in your body becomes cytotoxic, so it's actually got some of that DNA kind of destroying, seek and destroy characteristics in your bodily fluids, and that's your blood, your saliva, your tears, your sweat, your poo, your wee, and also your vaginal and semen fluids. Nurses will should tell patients about needing to use a barrier form of protection if you're actually having intercourse with a partner when you're on chemotherapy, and that's up to a week following the dose of chemotherapy. One thing that I know can happen is if you're on tablets, chemotherapy tablets, often you're taking those for a long time. The pharmacist might assume that you know all about taking that medication, and so it's just, I thought, well, I'm talking about sexuality, I better just talk about some of the safety stuff and say that actually if you're on oral chemotherapy, that's just as important while you're having that oral chemotherapy, and a week afterwards, after you've finished that chemotherapy, you're actually considered to be cytotoxic in your bodily fluids, and that means that if you're having intercourse or there's been a transfer of bodily fluids with someone, they may get a dose of your cytotoxic chemicals, which we don't want them to have because they don't have your cancer. So that's the kind of level of sharing that we just, we're not really up for. So I just thought I would mention that as an important point. The other thing that can happen with chemotherapy is we depress the function of the bone marrow, so that it affects the DNA and kills cells not only in cancers but unfortunately other areas of our body as well. So the bone marrow bone marrow function can be reduced, and that can lead to things like anemia, which can lead to things like shortness of breath or fatigue. But also for people immediately following chemotherapy, often they're more prone to infections, so that affects us in the bedroom as well. Sometimes people can get thrush as a consequence of that, and for women, that anyone who's had vaginal thrush can just, that's just the worst actually. It's so itchy and uncomfortable and painful. So if you're suffering in that area, again, there's so much we can do about it, but you've got to talk to your health professional about it. The other thing that can happen is that because of the bone marrow, you might have a reduction in the platelet level, which might mean that you're more prone to bruising or bleeding. So again, these things can affect us in the bedroom. The other thing that can happen with chemo is that we often get side effects on our skin. So we might get dry skin, or we might get mouth ulcers, which it's not going to put you in the mood for kissing, that's for sure. Sometimes diarrhea, and I'm going to come to diarrhea in a little while. So don't be worried about that. We will talk, because I always talk about diarrhea because I'm the net nurse. But the other thing about chemotherapy is it leads to hormone changes. So for women going through chemotherapy, if you haven't yet gone through menopause, usually you will. It's different from age, the normal menopause that happens as you get older, in that it's usually very, very fast. So the symptoms that you get from a menopause that's a chemical induced menopause it can be really quite severe. So we're talking hot flushes, and if you're getting hot flushes from your nets, well, you've got it coming from all directions. But also things like vaginal dryness can be really distressing. And as a young woman, if you're going through chemotherapy and that's shut your ovarian function down, that can be really confronting. And so for a lot of young women in that position, it can make them feel really old before their time. So dry skin, vaginal dryness, lack of flexibility in the vaginal tissue, where maybe even only a couple of weeks ago it was all normal down there, and it can change really fast. So there's lots we can do for that, and also talk with your doctor. Also, I'm always up for conversations about this. There's certainly water-based lubricants, but sometimes for women, an estrogen-based vaginal moisturiser may be appropriate for you. It depends a bit on what sort of cancer you've got, and there may be people who have got a history of breast cancer or another hormonal sensitive cancer. So we can't say that broadly, but certainly talk to your doctor if you're experiencing that. And as I said, give me a ring. I am so fine with talking about this stuff over the phone. I actually get a little bit, pleased when I feel like people trust me when they ask me about sex. So, I'm certainly up to talk about it. Radiotherapy. I don't want to lose my spot because I've got a lot to cover. Radiotherapy it affects us broadly in our whole body in terms of fatigue, and so chemotherapy can also lead to massive fatigue, but radiotherapy does mean most people feel fatigued. Radiotherapy also leads to hair loss in the area that's being treated. So if it's radiotherapy to your head, obviously that's really obvious, but if you're having radiotherapy to your pelvic area, you'll lose your pubic hair for a while. It does grow back. Sometimes it grows back a little bit different and a little bit thinner, but it does grow back. But again, these are things sometimes we forget to tell people, and they're like, where's my pubes? I feel a bit different down there. With radiotherapy, the part that's having the beam directly on it can lose some of its flexibility and some of its strength. So for women, if you're having radiotherapy to your pelvis area, we find that often the vagina can become more narrow and less flexible, and so it's really important to have that addressed. There's things that we can do about it, but it's much easier to prevent it than to sort it out if it's already if that tissue's already had big changes to it. We often talk in terms of nurses and radiotherapy units. We're really good at talking with women with gynecological cancers, sometimes women who are having treatment to their pelvic area because of bone lesions or something happening in the lower part of the bowel. Sometimes that can be left off. So if you're having radiotherapy, or you know someone who's having radiotherapy to their pelvis, it's really important that they get that information. Again, you can talk to me about that. I've worked in this area, so I'm really absolutely fine to talk about it. For guys, having radiotherapy to your pelvis, it can also affect the function of the penis. So we can find that, again, it can be harder to achieve an erection, and it can also be harder in terms of orgasm. So orgasm can actually, for some men, can become painful after having radiotherapy. That often gets better, but it's a nasty surprise, and sometimes men really worried that something's desperately wrong. So it's important to know that that can be part of the spectrum of side effects, and if you're experiencing that, let your doctor know. The other thing that can happen with radiotherapy to the pelvis for guys particularly is urinary incontinence. So that's more for people who are having really large doses of radiation to the pelvis because of prostate cancer, but it's something to bear in mind and get good education on. Generally, with the radiotherapy effects, I worked with a radiation oncologist who, his little mantra was use it or lose it. So if you're having regular sexual activity, that's actually going to help things stay functional longer term. If you have a break and you stop having any kind of sexual contact during the radiotherapy and afterwards, and then you try and get back into it, that's when it can be more difficult. So again, we want people to have the right information up front, and be encouraged that that part of your life doesn't have to switch off just because you're having cancer treatment. It's actually, I don't know, when you're having so much horrible medical touch, sometimes people tell me the only time they feel like they're being, they've got another human being touching them is to take blood or to take a blood pressure or stick a cannula in. I think these times more than any time in our life, we need that physical comfort. And so if that's helpful for you and if you feel like it, then there's no reason not to, with a few precautions and practical considerations. So the other thing with both radiotherapy and chemotherapy is that they affect people's fertility. So we know chemotherapy can put women into an early menopause. With men, they can become temporary. Usually it's temporary infertility, although with radiotherapy that can be more lasting. So if you're younger and those treatments are being prescribed for you, it's worthwhile talking to your medical team about whether there's something that needs to be done. So for females, if the ovaries are in the field of treatment for radiotherapy, we can offer, and also with chemotherapy, sometimes we can offer an IVF cycle to collect some eggs before you start that treatment. And for guys, we can do sperm banking if that's likely to be an ongoing issue longer term and you want to have children, or you may want to have children in the future. So that's important. It's an important conversation to have at the start. Like lots of things, it's much easier to sort it out before the treatment starts than to look back and go, oh gosh, if only I had known. So I've talked a bit about chemotherapy, I've talked a bit about radiotherapy. I'm going to talk just a bit more generally about cancer and the general effects that can affect us in terms of our sexuality. I've talked about fatigue, I've talked a bit about body image. Weight changes are really common with cancer, and that can be weight loss. So, that's probably what a lot of people think about when they think about cancer. They think about someone losing weight, but you can actually put on a lot of weight too. And with NETs, you can get a lot of abdominal bloating. So, they're not only affects our comfort, but it affects our sense of self-esteem, our body image, how attractive we feel. Like, if your muscles are shrinking down, you might feel less shapely, you might feel less capable, you might feel less strong, you might feel less manly or less womanly, and that all has an impact. Pain is a really common thing with cancer too, and obviously if you're sore, if you're in pain, you're probably not going to feel really particularly sexy, and so it's really important that we take that into account, and I'll give you, we've got some more practical strategies coming up too. There's a huge emotional impact, and it probably goes without saying, having cancer is a tremendously worrying experience for the person with the tumour, for those around them. There can be worries about coping with the treatment, it can be worries about how am I going to look after my family, how am I going to keep working, am I going to be okay long term, am I going to be able to pay my bills, all of that, so again, when you're feeling really stressed, it's much less likely that you'll be feeling sexy and ready for, up for something in the bedroom. So, these things can impact us in our sexuality. There can also be a real mismatch in desire between the person with the cancer and a carer. Now, sometimes we might assume that might be the person with the cancer feeling less desire, but sometimes it's actually the carer who's just so worried, and they're looking at their partner who might be unwell and just, they just don't want to hurt them, they've got too many other things on their mind, so there can be this mismatch in desire. Again, there's really good there's some fantastic strategies actually in the Cancer Council booklet, particularly on that topic. I was really impressed when I was reading the booklet about that. So if that's an issue for you, I probably, I'm not going to talk too much about strategies for that today, but have a look at that booklet. For people who are single, dating is such a minefield. It's so hard to work out, do I tell the person on the first date, on the fourth date, before we jump into bed? Maybe if it's an unexpected encounter that you want to become intimate with a person, or how to talk about that with a potential partner, and how will that partner respond, and will they be scared about entering a relationship with someone who's got that kind of complex health history? It's really complicated. And when you're single, as I said earlier, if the only time you're being touched is to have your blood taken, or to have a cannula put in, or to get the bill from the secretary and your hands brushed, you can be really starved for human contact. And so it's really tricky for single people, and when they're exploring dating. The other stage, which is, it goes without saying, but if someone has died in the family, that's a huge time of adjustment, and managing bereavement and the milieu of aspects of your life that impacts, even just missing that person in your day-to-day life, but then all of a sudden becoming single unexpectedly, and the impact of that. So I wanted to drill down a little bit more and just talk about NETs, because there's lots written, and this booklet is fantastic in terms of sexuality, intimacy and cancer generally, and pretty much everything I have said is in this booklet, so that's really good. But a lot of things, there's not very much written about NETs and sexuality, and it's an uncommon cancer. It's not an area that's written about even in cancer that commonly, so it wasn't a surprise to me that that I couldn't really see a lot of information and lots that had been written about NETs and cancer. But here's some stuff that I guess I know, because I work in the area. People have told me, and I've actually had a couple of conversations with some really helpful clinicians over the last week or so to help prepare for this talk, so my gratitude to those people as well. So the first thing a lot of people think about when they think about NETs is the the gut, the bowels. So we're talking diarrhea, we're talking gas, we're talking bloating, and gosh, it's hard enough when there's wind at work or wind on public transport, let alone wind in the bedroom. Having a bloated, sore tummy can be really uncomfortable and difficult if you're having an intimate moment with a loved one. And diarrhea, as we know, that can strike at any time. And a lot of people with diarrhea with nets actually find that urgency is it just comes on so suddenly that sometimes they also have struggles with incontinence. So obviously, if you're worried about losing control of your bowels, that's not going to be a great enhancement of your confidence in your sex life. So I'm going to talk about some strategies about how to deal with some of that stuff, and we've got some information online about that too that I'll put some links in the notes. There's also the hormonal impacts of living with nets, and that depends on the type of tumour. So if you've got an insulinoma that's producing lots of insulin, that's a really different type of situation hormonally to if you've got carcinoid syndrome and you're dealing with flushing and diarrhea. Or, if you've got a pheochromocytoma that's producing lots of adrenaline, and we're worried about having an adrenal surge and your heart blood pressure, skyrocketing, and your heart going out of your chest, jumping out of your chest. So these hormone surges can make people feel really scared about doing something different, and whether that's exercise, going for a brisk walk or going for a run, going for a bike ride. Sometimes people feel worried about, what if I have a hormone surge during those activities? Well, also, exercise in the bedroom, people are also worried about that as well. And sometimes partners can be worried. I don't want to make my partner sick. I don't want to make them feel stressed. I don't want to, I don't want to make them feel too emotional, because that might make them sick. And the person themselves with the tumour, well, gosh, if I get into something that's really quite vigorous, am I going to have a massive carcinoid syndrome episode or a carcinoid crisis? So again, these things are really important to talk with your doctor about. They'll be able to reassure you if you're, most people aren't at risk. Most people are not at risk of having a carcinoid crisis during sex. So talk with your doctor about it, and they'll be able to give you a much more personal, reasonable judgment about whether that's something we need to be concerned about. And if it is, well, there's rescue doses of octreotide that might be able to be employed. So again, that's a prescription medication. It requires a bit of forward planning, but if you're worried about that, that might be just the thing that gets you over the line into feeling a little bit more confident and comfortable about, okay, well, I know I've got some hormone cover here. If you've got a bit of a hair trigger carcinoid syndrome situation going on. The other thing, and this is an area where we know almost nothing about, is the impact of somatostatin analog injections on our sexual function. So we know that somatostatin analogs target somatostatin receptors in our body, and that shuts down the hormone production and the growth and reproduction of neuroendocrine tumours. Those drugs also link into somatostatin receptors in the other endocrine areas of our body. So we know that often pancreatic function is reduced when people are on these injections, and that means they're not producing the gut enzymes that they need to be producing, and that can result in not absorbing fats and proteins in your diet. And that's why a lot of people with nets are on Creon, and all of that is covered in other videos. But we've also got endocrine areas of our body that produce the sex hormone. So in women, our ovaries are producing, and our pituitary gland are producing estrogen and progesterone, and various other hormones that keep us ticking along as a female. And similarly for males, we've got the testes and pituitary gland are producing testosterone. So it's fascinating. It's not. I thought when I did talk with one of our endocrinologists about this, and I'm so grateful because he answered my emails in a very rapid time. I was kind of thinking that we might be able to say, oh well, it just sort of dampens down all of the production of sex hormones, but it's not seemingly that simple. There's some, and there's nothing in humans. We don't have anything that has really studied this in human beings. So we're kind of stuck in the laboratory with the poor old rats and mice, and the data's not really very conclusive. So I can't give you good answers about this, except to say that there have been changes noted, particularly around estrogen and somatostatin analogues. And I know a lot of women have told me that they feel like their skin gets drier, and that women who are menstruating on somatostatin analog injections have often said to me that their cycles go completely haywire with the injections. So I know, you know, from an anecdotal point of view, there does seem to be an impact, and there does seem to be some evidence when we're talking about our poor little furry friends and their blood results when they're on somatostatin analogues. And I guess it's probably it's an important side effect to be noting with your doctor. Maybe some of the reason that this hasn't been researched is that women might have been too kind of scared to tell their doctor that things aren't going so well in this part of my life, you know, because of all the things we've talked about. Doctors assuming that if it was happening, the patient would tell them, and patients assuming that if it was important, the doctor would ask them. So if you're having issues in that area, please talk to your doctor about it. It might be that some blood tests would help. It might be that some hormone replacement might be appropriate for you. I can't say that for sure for you. I'm not giving you medical advice, please no, but please know to talk to your doctor about it. The other thing that is worthwhile just mentioning is itchiness. So people with neuroendocrine tumours often have vitamin B deficiency. When that's severe, that can turn into a condition called pellagra. But even before it turns into pellagra, a lot of people with a vitamin B3 deficiency, I don't know if I said a bit of vitamin B3 before, but a vitamin B3 deficiency can lead to an itchy skin. And actually lack of estrogen, you can get itchy too. So if you've got an itch, make sure you tell your doctor about it. It might be actually that you're deficient in vitamin B3, which that's easy to supplement. We've got information on our website about that. I'll put a link in the notes about that. But the other type of neuroendocrine tumour that can cause itch is glucagonoma, and actually it's a very rare type of neuroendocrine tumour. But the presenting symptom in glucagonomas for a significant number of people, and particularly women, is itchy groin. And I've spoken to several women who have actually gone and seen dermatologists and skin doctors and sexual health doctors, and they've had STD testing, all sorts of things, because they've been really, really itchy in their genital area. And that's actually because of the excess glucagon, which is a digestive enzyme. So there are other hormonal syndromes that can increase the itch, both because of the vitamin B3 deficiency, because of too much serotonin being produced and depleting the body's stores of vitamin B3, or sometimes a glucagonoma. So if you're itchy, A, talk to your doctor, but B, it's certainly within the realms of possibility that could be related to your NET. Sort of seemingly independently of vitamin B3 deficiency and glucagonoma, I actually talked to quite a lot of women who have itching in their genital area with NETs. Now, I have to say that I've worked in lots of other areas of cancer, and that hasn't been something that a lot of other women have talked to me about with other sorts of cancers. And it might just be that I'm a bit older and people feel a bit more comfortable raising this with me now than they did when I was in my 20s. And obviously we haven't done a study in that. I've asked lots of oncologists about this, and they've kind of come up blank and said, oh, no one's ever mentioned that to me. And I'm thinking, well, we know why, because you don't ask and they don't tell. So anyway, I'm interested to know, like, if that's an issue. It's come up in our Facebook group a couple of times. I've had some conversations with particular women about it. But if you're having itching in your genital area, I think it's something that if we have enough evidence to say that this is happening more broadly, maybe we can do some more research into what's going on and what can be done about it. One of the people who's watching has just mentioned that there is a sex specialist at the Royal Melbourne, and this is probably coming into my next point, so it's a great segue, and that's to talk about strategies. So, and I'll probably come back down to the professional advice at the very end, so I'll come back to that. One of the little catchphrases that we used to use when I used to work at the Cancer Council, and I suspect it might have come from Dr Amanda Hordern and colleagues, is this catchphrase called lubricate and communicate. So a lot of these issues concern dry tissue, so we want to lubricate everything that moves with a water-based lubricant, and communication is really key too. So if you're feeling uncomfortable, if you're not sure if your partner's up for it, if you have become aware that things have kind of quietened down and you haven't kind of gone there for a while and there's like is awkward about it, I would just encourage you to be bold and to talk with your partner. But also, as I said before, be bold and talk with your health professional about it, because there may well be other strategies, medical strategies, that we can help you with to help in this area. The other little perhaps addition to communication and lubrication is inebriate, which my friend was told after she had a baby, which I thought was really funny. I now, not everybody with nets, alcohol doesn't agree with everybody with nets, and I'm not saying get roaring drunk, but if your doctor is happy with you to have a glass of wine, then sometimes that can be really helpful. If you're feeling a little bit nervous, a little bit anxious, and a little bit awkward, and a little bit worried, sometimes, just doing something like that to enhance the mood together before you even talk about it, that might be a good place to start. I know one doctor was asked, and it was one of our very popular sitting doctors, David, I'm sure he won't mind me mentioning his name, Dr. David Chan, when he's asked by patients if they can have a glass of wine, I think his usual answer is, oh, well, only if it's nice wine. So generally with nets, there's not a problem. For some of you, it may be a trigger food or a trigger drink. So obviously talk with your own health professional, but yeah, communicate, lubricate, and maybe inebriate. Planning ahead is really important, and it's sort of a little bit different from being young and spontaneous and being able to sort of just leap into bed, but sometimes earlier in the day can be better if you're fatigued. The other thing about planning ahead is sometimes you might want to just make sure you've got enough pain relief on board. So if you need pain medication regularly, make sure, if you feel like you might have a lovely evening together or a lovely morning together, get in early with your pain relief so that you're feeling comfortable. If you get carcinoid syndrome and you've got rescue doses of octreotide and you want to slip one of those in early too, then that's great to do. Sometimes lowering the bar and widening the focus. So starting really slowly, it might just be, saying, look, I don't feel like I'm up for the whole kit and caboodle tonight, but I would just love to cuddle. And actually being really open about communicating where we're going to go with this is really helpful for both people, or all people in that conversation. Having a massage and saying, we're just having a massage, and I don't have any expectations of anything further tonight or this morning or whenever, just to help us set the mood, but also just that skin contact that, as I said at the very beginning, the end game is not necessarily about having sexual intercourse. It's about being intimate together and just acknowledging that this is a really important part of our healthy lives. Padding any part of your body that hurts with pillows. So that might mean, a pillow under the knees, or a pillow under a hip that's dodgy, or, so making sure that you're comfortable. And when we're going to setting the scene, it's okay to dress to impress if you've got a stoma. Maybe a little camisole or a singlet or a nightie might be the thing that helps you take the focus off it. If you've got a stoma, actually, there's some really great stoma belts. They're built for exercise, but actually they can be really good for just holding everything in the right place while you're being more active, and not just about going for a jog there, perhaps. But also, scarves. If you've got a scar on your body that you're feeling nervous about, then it's okay to wear something to hide that. Also, taking down the lighting. If you being prepared for a mess, and certainly for people who have continence issues, this can be so confronting. It's worthwhile buying an absorbent waterproof sheet that you can put in your bed, and then you don't have to worry so much. And maybe your plan, as part of your being fun, having fun together, is having a shower together afterwards. So being prepared for mess, and maybe that also means burning some essential oil to give us some lovely aromas as well. Having some music to maybe help mask some of those unexpected sounds, but also, this is sometimes really funny. Nothing sounds more funny than a fart. The actual proposition of having sex with someone is actually sometimes really quite comedic, and so having fun, just sometimes taking the pressure off and having a laugh together can be such a fantastic release and lead to that feeling of intimacy and just feeling really connected to that other person. So you know, having fun and just relaxing is really important. And as the comment said earlier on, please do get help. There are sexual health counsellors, so you can talk with me about this, and I'm available around Australia, and I'll make sure my contact details are in the notes, but also the Cancer Council. The staff in each state on that 13, 11, 20 line have fantastic skills in this area. They all have training in talking with people about sex. So you can pretty well be assured that either myself or the Cancer Council people will be really... we're not going to get embarrassed if you've got an issue in this area and you want to talk confidentially over the phone with someone about this. We can refer you on to more services in your state that might, you know, if you need more help, or help sort of workshop the sentence that you might use to open the conversation with your health professional or your partner. So I think that's where I'm going to leave it today. And then next week, Dr Amanda Hordern is going to talk a lot more about that confidence, about getting your sense of your body confidence back, and more strategies and tips. So I'm really looking forward to welcoming her and introducing her to this amazing group of patients. She's heard me talk about you a lot, because we're good mates, and I'm really excited to be able to bring her along next week. So I wanted to just give a little bit of an update. I've just looked at the clock and thought, oh my goodness, I could talk under wet cement. So my apologies for yabbering on, but I really felt like it was an important subject to be covering that a lot of people don't cover. So enough. You will, unless you've been hiding under a rock this week, you'll know that not only was it Naidoc week, but on Tuesday it was World Net Cancer Day, which was a little bit different this year because of COVID, but we were still able to get everybody together virtually with the State of the Nation webinar. We heard from experts from all of the major treatment centres around Australia, from Perth all the way up, sweeping up right through to Queensland, and it was a really encouraging, informative session. One of the things that really struck me is that we have so many passionate and compassionate health professionals all over Australia who are working incredibly hard, not only to meet the needs and to treat the patients that they've got in their office at the time, but really importantly, the amount of groundbreaking research, the amount of creative thinking, and the amount of collaboration between the states that's happening is really quite mind-boggling. And I was really encouraged. I sat there watching the whole thing with a massive smile on my face, just thinking, wow, we really do have some good people on our teams. So I will post the video to that webinar is up. I'll post the link to that in the notes. It's a long one. It's like about 2.5 hours, so you might want to kind of, you know, watch it in segments. That's absolutely fine, but you're welcome to watch that one. The other couple of things that I wanted to mention to you is that the other thing we launched on World Net Cancer Day was our Net Champions campaign, which is really around celebrating the people who we see in our lives, really championing for NET. So whether that's a carer or a patient who you really admire, whether that's a volunteer who you see, you know, just contributing and doing amazing work, or whether it's a health professional in your life who you just really would love to give a public thanks to, a public round of applause. So on our website we've got some fantastic photos of some of the people who've been already nominated, and excitingly we've been given some sponsorship from a variety of companies to provide some gift hampers full of really treats and goodies for some people, so we're not every person who gets nominated will get a gift hamper, but we'll be sending those out in the following week. So I'm really looking forward to seeing some people's reactions to those gift hampers coming out as well. So if you nominate a person, the process I will make sure is in the links, but it's writing a short blurb about that person. We'd love a photograph. We won't publish the photograph or the name on the website without that person's permission, of course, but we would love to hear from you. Well, who are your champions? And it can be more than one person. It can be someone who's already on the website. If you're thinking, yeah, I agree, that person's made such a tremendous difference to me, I want to nominate them as well. That's absolutely fine. And speaking personally, someone did nominate me last week, and I didn't really think about that possibility, and it gave me such a surprise when ADR, Communications and Partnerships Manager, said to me, Kate, you've been nominated. It just really made my day. So I know we've got people far less visible than myself working so hard for the progression and the purpose of getting better treatments and outcomes for people with NET. So I would love to celebrate those people. So I'm really excited to see who comes up on our website next. Next week on Friday, we've got Dr Amanda Hordern coming to Facebook Friday, obviously, but also in the afternoon we've got our online Zoom group. I know we've actually got quite a lot of people who are new to our Facebook group, and you might be a bit confused by how the groups work. So we've got our geographic groups, which normally meet face-to-face, but they've all been meeting via Zoom lately because of COVID. But when COVID started, we decided that we would also start an open monthly meeting for those who may not be able to get to a geographic group even if they lived in that area. So they can, the links to that group are in our Facebook group, and I'll put a little comment on that, so hopefully it'll raise it up in your Facebook feed. Let me know if you can't find it. Those of you who, and the link to the Zoom meeting, so the link for Zoom, I put that out just a couple of hours. I put it up in the event listing just a couple of hours before that group meets. So keep an eye out for that next Friday morning. I'll make sure that link's on there so that in the afternoon, I think it's at 2:30. Between 2:30 and 4 off the top of my head next Friday. That's Melbourne time, so it's obviously different if you're in a different state. The other thing, just to say, I'm so excited that Erin Lang, who is a NET specialist dietitian, she's recently completed her PhD in nutrition and is looking at all these things about vitamin B3 deficiencies and all sorts of other stuff that's just been groundbreaking and will be life-changing for so many patients with NETs. I'm so excited about her research, and she is doing a webinar for us on Tuesday the 24th of November. Now that's for patients, but it's also for health professionals. So if you've got a health professional who you've been, who's been kind of thinking, should I prescribe Creon? Should we be supplementing with vitamin B3? Are there other things that we should be doing blood tests for vitamin levels? What are the recommendations? Then that would be a really good webinar to tell them to come along to see. The information, if it's not on our website today, then it will be very much early next week. It'll be there ready. It'll also be on YouTube afterwards, so you can always send them the link after the video, after the webinar's done. And then a couple of weeks after that webinar, we're actually getting Erin to come back into our Facebook private discussion group to catch up with some Q&A, because she's only got an hour on that. We've only got an hour for that webinar, and I think it's going to go fast, and there may be lots and lots of questions from people. So we'll get her back the following week for a Facebook Friday session where we can really grill her on what the actual evidence means for people living with NET. So I'm very excited about that. So to finish off today, it being Naidoc week, and having talked a bit about the importance of relaxation, I did see a beautiful post about Naidoc week from Smiling Mind, who are an organisation who promote mindfulness meditation for the general public. It doesn't have a cancer focus, but they've got an app with heaps of different beautiful meditations. Some really fantastic people who are narrating those. And this week they featured a relaxation meditation by a really fantastic Aboriginal man called Jack Charles. So I will put a link to this in the notes. I just thought it was so, I just loved it. It's about 10 minutes long. And I thought, well, if you're going to listen to a meditation to help yourself relax, it being Naidoc week, maybe these are the beautiful vocal tones that might be good to listen to this week for you. So I'll make sure that's in the notes for you as we finish up today. So I'm just going to have a look at the questions and just make sure there's nothing that I really need to address before I sign off, because I press finish and then I think, drat, I was going to say this other thing. So and there's actually some really good tips and strategies in the notes, so I think that might be really useful to have a look at if you're in our Facebook group. And if you're watching this on YouTube, I'll make sure the link to the Facebook group's in the YouTube channel too, in the YouTube notes. So I think I probably have answered all of the questions that I can answer today, but someone has just asked about intimate relations. That's a very, very polite way of saying sex, but great during treatments such as chemo and radiotherapy to protect the other person. So I think we did cover that, but just to make sure that that you know. So it's up to a week following the end of that treatment. So if it's oral chemotherapy, it's a week after the last tablet. If it's intravenous, it's a week after that drip. You don't need to worry about protecting an intimate partner with radiotherapy. That doesn't make you more prone to making that partner radioactive. Having said that, I've just thought about PRRT, and I don't actually know the answer to that question. I think probably we would consider bodily fluids, those bodily fluids as well as urine, to be mildly radioactive, and I need to do a bit of research. So I will ask our doctors and let you know about what the answers are next week. So it's good that we've got a 2-week series. So I'm going to ask about PRRT and if there's safety precautions with sex after that treatment, and I'll let you know. Yeah, I'm going to have I'll have another look at the questions afterwards, and anyone else I'll follow up next week. It's been really lovely to talk with you today. Thanks everyone for joining me on what is sometimes a really complex and deeply personal topic. I'm in the office this afternoon, so if you need to talk about any of this, you know how to find me, but my phone number will be in the notes. And I hope you have a lovely weekend, everybody, and I look forward to connecting with you soon. Take care.